Well, good morning or good afternoon. Looks like we have a good group here. So it is my pleasure to have Carly Dawson here with us presenting her work for her master's thesis in genetic counseling at Bay Path University, looking at diversity measures in clinical genetics. And this was something that I actually participated in with Carly. She'll tell you all about it, but we did a workshop at the Wisconsin Genetics Exchange. And we really were informed a lot by the work of the Ancestry and Diversity Working Group of ClinGen and sort of building on what's already been learned through our surveys and our other efforts. And this is a sort of interactive take on that, which I think was really informative, and there's lots of great things coming. And so Carly has just done a fantastic job leading this project, doing it almost entirely on her own. I sort of consult with her, but really this is her work, and I'm just so delighted that she's here to share it with us today. So Carly, if you want to go ahead and share your screen, you can take it away.
All right, thank you. One moment here while I pull it all up. All right. So you should be seeing my screen, correct? Without the presenter notes?
Yep, looks good.
Okay, perfect. All right. Well, thank you, Alice, for the introduction. And I like Alice said, my name is Carly. I'm a graduating genetic counseling student at Bay Path University, and I'm excited for the opportunity to present to you all today. And we'll be presenting on the results of the study that was for my capstone thesis titled Diversity Measures in Genomic Medicine. First, I want to start off by reviewing what diversity measures are and the problem that we've identified. So race, ethnicity, and ancestry are diversity measures that are used to collect demographics in clinical and research settings. And however, there are no consistent or universal definitions between these three terms, which leads to interchangeable uses. So then, how do diversity measures impact genomic medicine? Well, it starts with how the information is collected and also the impact on current genetic databases. So populations, or the completion of the Human Genome Project had led to a better understanding of all the genes in humans, and that has been used as the reference genome to understanding genetic disease. And populations from different ancestries have genomic variations that may be specific to each population, and as a result, the reference human genome sequence does not reflect all of that variation. Unfortunately, current genetic databases primarily consist of European ancestral populations, and this has led to patients that are of non-European ancestry to be more likely to receive an uncertain result or a false positive. Due to the lack of standard definitions and interchangeable use of diversity measures like race, ethnicity, and ancestry, this has led to disparities in healthcare, including accurate variant interpretations and classifications. Previous literature has highlighted some of the presenting issues in this field and the use of race, ethnicity, and ancestry. For example, Popejoy et al. Has summarized that test requisition forms are inconsistent, asking for different information that may range from race, such as Caucasian, African American, Asian, Hispanic, to more specific ancestries and regions of the world, like Eastern or Western European, Middle Eastern, Pacific Islander, etc. In addition, Casnet et al. Has illustrated that patients that self-report or have unknown ancestry are not offered as comprehensive testing options, and this has led to missed carriers of genetic diseases for certain ancestries. And misleading patient care was illustrated by Landry and Ream, who evaluated the detection rates for cardiomyopathy testing across different races and ethnicities, and found that results revealed a significantly higher detection rate of positive results for white individuals, and also a lower detection rate of variants of uncertain significance in white individuals compared to those that are non-white. So the problem that we have identified and that we're familiar with is that the current genetic databases lack diversity, which is resulting in disparities to underrepresented populations. And the interchangeable use of the three terms race, ethnicity, and ancestry have led to inaccurate data collection, incorrect variant classifications, as well as misleading patient care. For our study, we wanted to evaluate how genetic professionals define and utilize this information effectively within their practice to help guide future guidelines. So we asked, how do genetic professionals define these terms? How do they use it within their clinical practices? And also, is the current use of race, ethnicity, and ancestry appropriate for their intended use? To do this study, we designed a mixed methods survey and distributed it to the 2021 Virtual Wisconsin Genetics Exchange Conference. And after an expert presentation provided by Dr. Alice Popejoy, conference attendees were divided randomly into breakout sessions to begin a 60-minute workshop. This survey the survey was distributed to the participants, and it consisted of 21 multiple choice and open-ended questions created through Qualtrics survey. Not all questions were requiring a response, and some questions allowed for more than one answer. And participants were encouraged to work through the survey and, when prompted, to discuss their responses with the group as they felt comfortable. Data analysis for quantitative data was analyzed through Qualtrics survey, and qualitative response were reviewed for common themes. So first, we'll take a look at the demographics of our study. Overall, we had a 63% response rate, which primarily consisted of genetic counselors and genetic professionals that had 1 to 5 years of experience and also worked in academic or university institutions. And then our first set of results will be looking at how genetic professionals defined diversity measures. Participants were asked which of the following group concepts describes some aspect of race, ethnicity, and/or ancestry. And the heat map here, the heat distribution here shows that race was mostly associated with a social identity group. Ethnicity is strongly associated with a cultural group, and ancestry was strongly associated with a with a genetic lineage group, but then also had a high moderate association with a biological group. The heat distribution here also demonstrates overlap between the three terms and the group concepts, as well as some inconsistency between the definitions. Participants also provided their own justifications for how they had differentiated the three terms. For example, a laboratory genetic counselor had shared, for many of us, ethnicity and ancestry mean the same thing. Race is an unclear and unspecific term that has more to do with skin color and less with actual genetic background. And then a pediatric and general adult clinical geneticist had shared that race is an artificial construct originally created to justify slavery and exploitation. Ethnicity refers in part to our ties, both the physical location and to society and culture. Ancestry, I relate to all aspects of ourselves that is hereditary. So these quotes, among others, describe race as being sort of like a social construct or even a physical trait. Ethnicity as something related to culture or society, and then ancestry being more so of your biological background. Participants also reflected on the purpose of race, ethnicity, and ancestry terms and how they may be used in clinic, as well as some of the similarities or differences among the conversations in their groups. Perceptions of this included that the task in general in looking at these terms, it was difficult to define them. There was a lot of overlap, interpretation differences, meaning between either group members or between a patient and a provider, and then even feeling uncomfortable. And then potential influences included personal experience, identity, background bias, similar clinical training, as the majority of many of the participants were all genetic counselors, even practicing in the state of Wisconsin, and then even some influences like social media or exposure or education on certain current events. So to provide a couple examples of some quotes that I wanted to share that emulate these perceptions. For overlap and difficulty defining, a cancer genetic counselor shared that we had trouble with parsing out the differences, as well as discussing how these definitions may be confused when discussing and asking patients about these as well. And then a trainee had also stated that we spoke about ethnicity and ancestry and how we've used them interchangeably. We weren't entirely sure how to distinguish the two. We felt that it was important to share that we all struggle with defining ancestry and ethnicity in general life and clinic. Next, looking at some of the interpretation differences, a pediatric genetic counselor shared that we discussed that our patients may use one or none of these definitions, or may think of their country of origin in an entirely different way. So even if we feel we have under trainings or definitions, our patients may think about this in a different way. And then lastly, looking at participants that shared that they felt uncomfortable. A prenatal genetic counselor shared that it made me feel that I was not alone in finding this difficult to do. The others in my group also felt uncomfortable answering some of the questions, and we did not think species could be classified in any of the three categories. For a prenatal cancer genetic counselor, they shared that they also felt somewhat uncomfortable and even felt pigeonholed in some of these definitions. So these quotes, among others, are demonstrating that the task is difficult to do. There's a lot of overlap and inconsistency in the interpretations. And this can be based on many influences, just based off of someone's personal experience, identity, background, and can even make participants feel uncomfortable. The second set of results is looking at the utility of diversity measures in genomic medicine and how or if genetic professionals utilize this information in their own practice. This figure here is showing which diversity measure was utilized most by genetic professionals. Overall, ancestry and ethnicity was utilized most, and again, primarily made up of genetic counselors, but we also see an overlap between the three terms as well, between race, ethnicity, and ancestry. Participants were also provided 5 common scenarios and asked for which of the following they utilize race, ethnicity, or ancestry. And for obtaining consent, the 3 terms mostly did not apply, or genetic professionals utilize ethnicity potentially to understand values or beliefs while consenting to testing. And then ancestry was utilized most in decision-making, contextualizing results, as well as clinical variant interpretation. And I actually found it most interesting that for tailoring treatment or tailoring care, the majority stated that it did not apply. Participants also shared additional use cases or scenarios for utilizing race, ethnicity, and ancestry. And these included demographics on test requisition forms, utilizing the National Comprehensive Cancer Network guidelines, defining carrier risks or residual risks, guiding test offerings, interpreting results or interpreting VUSs and the significance to non-European patients, insurance purposes, pedigree risk analysis, tracking health equity, and then also interpreting ultrasound findings or dysmorphology. So to highlight a few example quotes that emulate these emerging use cases, a pediatric genetic counselor had shared for demographics for test requisition forms that they discussed filling out this information on clinical genetic test forms and how different forms have different wording. We also discussed that patients respond differently and will provide different information between race, ethnicity, and ancestry. So some patients may describe themselves as white or Caucasian, while others will describe it as German, English, Italian, or Irish. So this is going back to the test requisition forms and further describing that inconsistency between the forms and the labs and what they're requesting. And then for the National Comprehensive Cancer Network guidelines, or NCCN, NCCN guidelines are a set of criteria utilized in cancer to guide intervention or management decisions. And this also includes genetic testing. So for example, for breast cancer, there's a set of criteria, and I should add there's various ways to meet this criteria to determine if a patient, if genetic testing is recommended for a patient. And one of that criteria is Ashkenazi Jewish ancestry. So these two quotes sort of emulate that, stating that they discussed how Ashkenazi Jewish ancestry could make or break, so to speak, someone from meeting NCCN criteria. And then the cancer genetic counselor shared that group members who work in variant interpretation use Ancestry, and group members in clinical care use it occasionally when determining if patient meets criteria for genetic testing. So it's really stating how, Ashkenazi Jewish ancestry can determine if a patient meets criteria for testing or if insurance would even cover it. For interpreting variants of uncertain significance to non-European patients, a cancer genetic counselor shared, when interpreting clinical variants, some variation has increased risk for certain populations. I think about certain ancestries and the challenge of not having an adequate reference sequence and the higher likelihood of getting a VUS. I do more anticipatory guidance for individuals with non-European background when ordering large cancer gene panels, and I need to explain VUS differences in more detail because I want them to be prepared for an uncertain result. So this quote is demonstrating that additive counseling technique for non-European patients to anticipate higher likelihood of uncertain results and the need for diversifying those genetic databases for adequate reference sequences for more accurate variant classification. And then lastly, looking at some of the interpreting ultrasound findings and dysmorphology, a prenatal GC had stated that for prenatal ultrasound findings, specifically looking at hypoplastic nasal bones or echogenic focus, that may be more common in an Asian ancestry. And then a pediatric genetic counselor stated that we note a patient's ancestry, race, or background to help with dysmorphology. And they provided the example of hypertelorism, which may be more common in those with African ancestry. And so while these quotes are sort of sharing how this information has been used for interpreting ultrasound findings or dysmorphology, we've also sort of thought about this as a way of racial stereotyping for patients as well. And this transitions into our final set of results, which is looking at the clinical utility and validity of diversity measures. Overall, only 4% of genetic professionals in our study stated the use of race, ethnicity, and ancestry was appropriate. This included one genetic counselor, one clinical geneticist, and then one other clinical role. And then 20% stated it was not appropriate. And while another 44% stated that it depends, and 32% stated that they weren't sure. Regardless of how participants responded to the previous question, they were asked to provide scenarios for which using REA was effective or ineffective in their intended purposes. So summarized on this chart are the cases for which participants believed the utility of currently available data is appropriate and effective. And this includes variant interpretation, specifically responses summarizing the US resolution or disclosing results to non-European patients. Other appropriate cases included providing carrier risks based off of a patient's race, ethnicity, or ancestry, and reviewing the known carrier risks or founder mutations for diseases of a specific population. Test offerings was noted as an appropriate use case, and then also understanding barriers to healthcare and tailoring care or management. Scenarios for which participants had believed was ineffective had also included test offerings, which I found to be a little interesting. So we see that there are conflicting views on whether the utility of REA is appropriate or not appropriate for test offerings. And I think the following quote sort of summarizes that contradictory statement. And this participant shared, although it is common practice to use these categories to guide carrier screening or test selection, there has been data that shows contradictory information that it should not be used, and widespread carrier screening should be offered. So regardless of someone's REA, comprehensive carrier screening or testing should be offered. Other ways in which REA was considered to be not appropriate was if the data was self-reported. So a participant had shared, many patients do not truly know their ancestry, so we may not be recommending appropriate tests based on reported ancestry versus true ancestry. Additionally, genetic syndromes are still present in non-high-risk populations. And then looking at the psychosocial impact for patients, I won't read the full quote, but just looking in on the second sentence saying, in some cases, it can lead to unintended psychosocial implications, such as making people feel inadequate, shame, anger, grief for not knowing their ancestry, being estranged, or even being adopted, and can divert the conversation away from important counseling concepts. Also, this participant shared that they worry that undocumented immigrants may feel threatened by how the information may be used. In addition, 12 participants had noted that there were no cases for which the utility of race, ethnicity, or ancestry is appropriate. And therefore, in all of the cases, they had assumed that it would be inappropriate. But in 7 of those 12 responses, participants specifically called out race, stating that it should not be used. However, historically, race has been used as proxy for ancestry, as seen in previous literature. And a clinical geneticist had shared, as a general rule, I do not find race very useful, particularly as defined in the US. It is a poor surrogate for knowing the ethnicity and ancestry of an individual. One obvious practical problem with using race is in clinical genetics is a large fraction of the US population that is of mixed genetic ancestry. So we know access to this ancestral information does come with barriers, like it being difficult to obtain, costs. So what can we do when patients provide their race? And I think, as we always say, trying to make it consistent across the board, but for patients that are providing their race, a prenatal genetic counselor had stated that they think it's okay for race to be used if patients use it, and then it can be a jumping off point. For example, if a patient provides Black, a provider can follow up and ask, do you know any additional specific countries of origin for your family, such as African or Caribbean, etc. And this open-ended version of the question is important. So if patients do not have additional information, you've left them that place to say so, or you've encouraged them to consider countries of origin that they may not have thought of if they didn't understand the question right away. Moving on to the discussion and addressing the research questions. For definitions of diversity measures, we did see a lack of consistent use and definitions of race, ethnicity, and ancestry across clinic and research. And there were feelings of confusion, uncomfortableness, and difficulty in defining those terms. Results also established baseline definitions and supported previous findings by Popejoy et al. Regarding ancestry as biological and race and ethnicity as sociocultural. And this may demonstrate a pattern within the field, and repeating this study across national conferences or statewide conferences may increase that recognition of the definitions and the lack of the consistent use of the definitions, and could further suggest guidelines. For the utility of diversity measures, it elicited some common scenarios or use cases for which diversity measures are utilized by genetic professionals and where it may be appropriate or effective to use the information. Ancestry seemed to be the more accurate indicator of genetic variance, and supporting previous studies by Nelson et al. Stating that race should not be used as proxy for ancestral information. Lastly, regarding the utility and validity of race, ethnicity, and ancestry, while there are some elements and scenarios in which race, ethnicity, and ancestry information is not appropriate, regardless of an individual's REA, they should be offered comprehensive screening options because of risks for self-reported ancestry, which may be inaccurate as patients come from mixed backgrounds. A previous study actually did evaluate the effects of self-reported ethnicity, and this led to missed carriers of specific diseases within at-risk populations. So while obtaining accurate ancestral information may come with barriers, we can make a collaborative effort to ask questions in more consistent ways across clinic or lab, and accurate information then may diversify the genetic databases to better classify uncertain results and inform a better impact on different populations. Some of the implications, while there is still much research that needs to be completed to develop standardized guidelines, these data do propose a few recommendations for where the field may start. And this includes avoiding the use of race as proxy for countries of origin, unless the patient does not understand the terms ethnicity or ancestry, or even providing examples of additional countries of origin to help encourage thinking about those countries of origin rather than just providing the race, and to avoid assuming one's ancestry based on information in the chart. In addition, providers may consider describing the purpose of why this information is asked. So this may as well ask or encourage patients to consider their countries of origin as a more accurate descriptor. And lastly, laboratories may consider consistent ancestral selections on their demographic forms, or potentially open-ended options for REA for providers to fill in based on what their patient reports. Often patients may report their ancestry, but the lab requests a race to be identified, and this may lead to a provider assuming the race based on ancestral descriptions, what's in the chart, or even the appearance of a patient. Notes for future research. This study design and workshop provides a template for other statewide professional conferences to determine their own definitions and the use cases of race, ethnicity, and ancestry. And further research in this area can help explore consistent gaps and help guide some framework for future standardized guidelines. Limitations of the study. Overall, there were no designated scribes for the groups, which could have resulted in less detailed responses, as well as did lead to some vagueness in some of the responses. And for the group discussions, some participants may have been more reserved in sharing their thoughts, feelings, or opinions. And just due to the small genetics community within Wisconsin, it is possible that participants did not reveal much in their groups if they were in groups with colleagues, or if there was someone in their group that was of a higher position. As well as for the demographics, many participants were genetic counselors within the field within the state of Wisconsin, and they shared similar clinical training and experience within their own practices. So this potentially resulted in a low professional diversity within the study sample, and overall could not be characterizable for all professionals within the genetics community, but definitely encouraged to be repeated to try to improve that diversity for professional diversity. These are the references that I've used, and I want to thank you all for listening, and also thank Dr. Alice Popejoy, as she was a wonderful mentor for me throughout this project as well. And with that, I am happy to take any questions that anyone may have.
Fantastic job, Carly. Thank you so much.
Thank you.
Any questions?
Carly, I had a quick question. You mentioned a couple times about, thank you, it was really, really well put together and presented. You mentioned a couple times about state groups getting together, but there aren't really formal state groups across every state that I'm aware of. Like, there is a Texas Genetic Society, but it's not necessarily made up of the clinical geneticists and testing laboratories. So I was sort of wondering how you would see that actually rolling out in other states.
Yeah, and that's a good point. I know within the state of Wisconsin, we have twice a year, I believe, we have the genetics exchange. And so we're able to, as a state, come together and hold a conference. That's actually a good point that you bring up, that, you know, I'm not sure how other states do that. And if there are, you know, specific statewide conferences that are held for, you know, like using Illinois as an example, you know, does Illinois have a specific conference for Illinois genetic professionals to come together? That was sort of my idea of that, but I guess that's a good thing to look into and make sure that other states have that opportunity.
Hi, this is Altavis. I can affirm that Illinois has a state society. I'm actually speaking at their upcoming meeting this Friday. But I would also say that it is pretty common among several of the states. Now, what Sharon has pointed out is like the composition of members within those state societies. I do think the majority of members are genetic counselors. And I think part of that has to do with those state societies or organizations really being convened to help with licensure issues within the state. So just kind of wanted to add that.
Yeah, that's a good point. Thank you.
Okay, it looks like we have another comment here in the chat. Thank you for this comprehensive research. I'm curious if any participants expressed that having whole genome sequencing of patients would solve this problem of REA use in clinical care.
Yeah, that's a good question. I actually did not see that pop up in any of the open-ended responses. But that is a good, maybe something that potentially in a future study, that could be a question that's asked just to get perceptions of genetic professionals, what they think of that. But for this study, I did not actually come across any of those responses that mentioned that.
I wonder if our audience member, Mariani, if you would be willing to elaborate your thoughts on that, just since it's a thread.
Hi, sure. Sorry, I can't be on video at the moment, but yeah, so I'm actually working on a study with Galen Joseph at UCSF about asking both patients and clinicians sort of what their thoughts are on the possibility of having patients' whole genomes in the electronic medical record. And so I was just curious if, you know, sort of beyond maybe genetic counselors, what clinicians might think about the potential of that, and if that might, yeah, I guess sort of like solve this problem of origin. And okay, now we know what tests to ask, or if maybe there's possibility of that not entirely addressing how we understand, like, let's say, social determinants of health and what actually affects health disparities. So I was just curious if there was conversation on what that could provide if that was possible. So yeah, thank you so much.
Yeah, thank you. Yeah, from what I had reviewed, I didn't see anything about that, but that is definitely something interesting that I would like to, like you said, you know, genetic counselors and other genetic professionals, what their thoughts are on that.
Thanks so much.
Other questions? So Carly, and maybe others on the call, since we are here within ClinGen hosting us, I'm curious about the portability or the scalability of this type of a workshop, not just for a statewide organization or setting like the Wisconsin Genetics Exchange, but let's say members of the Ancestry and Diversity Working Group or colleagues wanted to go out and repeat this workshop in some local setting. I mean, how feasible do you think that would be? What would that entail? And then from the audience side, you know, would there be interest potentially in rolling something like this out?
Yeah, I think this was that's a good idea. I think this is a good pilot that we had done with the state of Wisconsin. And I think it is definitely, it can translate over well to other, you know, groups or conferences that want to try to replicate it. Essentially, you know, how we had done it, we just had everybody break out into breakout rooms randomly. and they were able to, our survey, they were able to either work on it by themselves on their own, or if they were prompted throughout the survey to discuss answers to specific questions as a group, and then document, how that informed their opinions or perspectives on the questions. But I think that's definitely, it can translate over well to other groups that want to, use this study to try to obtain a little bit more information or perspectives from their groups or conferences or organizations.
Okay, cool. And so for working group members or other folks, just in general, how do you feel about the idea of potentially putting together some sort of a template for this workshop where we have maybe an educational video, which would sub in for the, the talk, and then really like just a set of questions within a Qualtrics survey, which we already have, and then really sending people out into breakout sessions, and then coming back together so that we could sort of start to like collect bulk amounts of data like this as sort of either in conjunction with or in parallel to the survey effort that we already have underway. All right, well, I'll let folks ruminate on that since we do have some comments in the chat. So first we have a question from Barbara Koenig. How strong is the evidence that knowing genetic ancestry improves outcomes? You reviewed the literature at the start of your talk.
Can you repeat that question again? Sorry.
How strong is the evidence that knowing genetic ancestry improves outcomes?
So I think that really kind of relates to how some of the participants had shared whether it was appropriate or not appropriate. In many cases, Ancestry was helpful in determining, what type of, diseases a specific at-risk population may have. So in that case, it can really improve, what type of information you're providing your patient and those carrier risks. It can also, if you know that information or if you know that ancestral information and it's accurate, offering that test for them so that they are able to, get that information and find out, if they are at risk for having that disease because they are of that ancestral or ancestry. But yeah, I think there are a couple ways that it can kind of improve, a patient's care. But like we did see too, there are some, inappropriate use cases of this as well. Does that answer your question? I'm sorry.
So I think this one is really more about like what evidence do we have? I mean, what you shared is helpful just to think about how the survey participants and the workshop participants were thinking about the utility of Ancestry. But I think Barbara's question, correct me if I'm wrong, Barbara, that this is really about when you actually have access to genetic ancestry estimates, do we have evidence that improves outcomes? And I don't think there's data on that. I think that's something that obviously we're working on in the CSER consortium that Neil Rish's project on diagnostic yield is sort of, taking the lead on that. And certainly not from this study. And I don't know of any other research in the literature that establishes that either way.
Mm-hmm.
Alice, that was indeed the question I was trying to ask. So thank you for stating it. Clearly, it just seems to me that the answer to that question sort of presupposes this larger project of doing this kind of education and assessment of how people. That's the justification for continuing for this work. So I just wondered. I'm a bit confused about how much evidence there actually is at this point.
Oh, I think I would answer it a little differently. Part of it has to do with the point that I think some of your respondents made, which is that there are current guidelines that are based on ethnicity/ancestry, right? So if we were smarter, in my opinion, and we're doing population screening of tier 1 genes, then it wouldn't matter if you know if someone's Ashkenazi Jewish or not, because every young adult would be offered BRCA1 and 2 testing. But if you're stuck in the guideline situation we're stuck in, then you would be better off with ancestry information than self-report information, because not everybody knows they have Ashkenazi Jewish background. But it gets very circular, because if you're going to have enough genetic information to know someone's Ashkenazi Jewish or has Ashkenazi Jewish ancestry, then you could just look for those variants in everyone, right? So we have sort of this illogical set of guidelines, which insurance coverage very much follow, that say certain people with certain self-reported ethnicity get certain kinds of tests. So as long as, at least in the US, we're in that system, we're sort of stuck either asking or learning something about ancestry.
Mm-hmm. And what came to mind for me was definitely the whole chicken and egg problem. I just reflect on the current state of the data that is collected today, or that's available to us, and there is much room for improvement. And there is much room for improvement in even the questions that we are asking, and even asking the right questions of the right patients. So I really think there is a need to increase awareness to ensure that we are, in a sense, like standardizing or at least collecting quality data from all populations, and then kind of assessing the impact of it, and then justifying whether or not there's the need to improve upon it. But I would say that the majority of us know that this diversity measures is not something that has received the attention that it has deserved. And as a result, several marginalized and underrepresented populations have suffered as a result. So I'm in favor of this is an opportunity to make a difference, and it may start with awareness. And once we've increased that awareness and we see some behavioral change, then let's collect the data to assess how we can further refine our interventions and generate more evidence in the future. So yeah, just reflecting on the chicken and egg problem.
Yeah, and that's a good point to make. I've even just in my clinical rotations, when I've asked, my patients what their ancestry is, sometimes they do provide me with that race. And so I've gotten in the habit of explaining, why I'm asking of this information. And even sometimes when I ask this information, patients are like, why are you asking that? Why do you need that information? And so I've gotten in the habit of starting to explain, why we ask for this information, and then even going a little bit deeper by saying, what countries of origin might your family be from, instead of saying, what's your ancestry? I kind of just ask it in a different way. And that I've found, at least for me, that that's helped get a little bit more information from my patients rather than them just providing their race.
Okay, thank you to everyone for sharing so far. We've got some more in the chats. So question from Clarissa: as part of the workshop, did you examine whether there was variation in responses or trends in responses correlated with respondents' self-described race or ethnicity? As you previously pointed out, we have a significant lack of diversity in the field when it comes to relatively homogeneous biobank data, et cetera. And this is an area where I feel lived experience may alter personal relationship to and perceptions of these terms and their use.
Yeah, that is a good question. I don't think that I had done that within my review of the data, but definitely something that I could potentially look at a little bit deeper to try to get that information, just to see, how that correlates a little bit more.
But we did look
and
at
that sort of relates to Joanna's comment as well about in the chat about the makeup of workshops.
Okay, did everyone at the conference participate, or were the participants limited to attendees who chose to join this particular session of the conference? I can speak to that, Carly, with you, but please feel free to start off. You can fill in.
Yeah, sorry, I just found the chat here, so now I'm able to kind of like follow along here. But sorry, can you I'm just trying to find that question
Yeah,
in there.
so
If you can
from
just,
Joanna Bulkley, it's about, did everyone at the conference participate, or were they limited to attendees who chose to join this particular session?
so everybody, so this was the, Alice was actually the keynote speaker for this. So this was the first presentation of the day. And we had that everybody that was on were able to, we told them that they were going into breakout sessions, if they didn't want to participate. So everyone that was at the conference were able to take part in this session. And then for anybody that didn't want to participate in this, they were able to exit the workshop, exit the breakout rooms, and they did not submit their surveys.
I will say also, just a little bit of background. Initially, Jenny Gertz invited me to give this keynote at the Wisconsin Genetics Exchange. And at that point, I had just said, I'm all done giving 50-minute talks on this, or even 40-minute talks and 20 minutes of Q&A, because there's so much richness to happen in terms of the educational component and really seeing it as an opportunity for intervention. So we started brainstorming, how we might do an interactive session instead of just a boilerplate keynote for the whole conference. So we actually sent out surveys in advance of the Wisconsin Genetics Exchange that were almost the exact same survey as we did in 2019. From the Ancestry and Diversity Working Group, with just a few changes that were just errors in the, the background flow coding logic, et cetera. And then people who wanted to participate, I think some of them didn't know, right, Carly? There were some participants who were like, we did not show up to this expecting to be in breakout rooms and interacting with people. So there were some grumbles about that. But for the most part, it seemed like people were happy to start off the conference with an interactive session. And I don't know, Carly, do you know how many opted out? Like when we did the informed consent at the beginning, how many just decided to exit at that point?
I do have that. I don't have that in front of me. But I do know just from, hearing that participants that, when you're in a virtual conference, I think this is also kind of one of the limitations, is that when you're in a virtual conference, emphasis on virtual, you might be, multitasking or doing other things throughout the session. It may not completely be, present during that session. And so I think a lot of participants at first did miss, what we were doing. And then when we did go into the breakout sessions, they were kind of confused on what we were doing and what we were asking for. So there was a little bit of, backlog and needing to kind of restate what we were doing, to go through and decide if that was a study or a workshop that they wanted to participate in. So yeah, there was a little bit of retraining, and we did too in the beginning. Jenny Gertz, who was the host of this conference, she did do just a brief kind of recap on what respectful conversations are, to be present during the virtual conference, just because I don't think we were the only session that day that had a workshop. So we definitely did try to kind of talk to our participants to get them to be as present as possible. And to have respectful conversations.
Yeah, and I think also there's a trade-off, right? There's a trade-off with obviously limitations of this approach, and also the benefit that anyone who's attending the Wisconsin Genetics Exchange was thrown into this workshop, right? It wasn't that they selected this to be educational on this topic. So I think that was reflected in the responses, that there were some folks for whom this was sort of brand new information and not necessarily welcome, but in many cases, right, people seem to really be glad that we're talking about it. Okay, so in the chat, I see a few comments from Hannah and Joanna. I wonder if you want to just chime in and based on where we are in the conversation now and ask your question or contribute your comment.
Mine was a little bit of concern, I guess, with the timing of it being right after a keynote or expert talk and then asking people for opinions. Especially if people were disclosing that this was an uncomfortable topic for them, I think if I were putting myself in their shoes, I would struggle to say something that was opposite of what I just heard, with the desire to like appear correct to my colleagues, or I'm forgetting the bias of what that's called, but yeah, it'd be interesting to have done the workshop maybe before at a different point, or maybe not immediately after, to see if there was more variability in how people are responding.
Yeah, and now that you bring that up, I think it just kind of reworking what we could have done for the workshop. Potentially, we could have broken up we did have our survey broken up into the three sort of sections that I divided my results into, but even potentially creating a presentation that is more so interactive. So maybe talking about, gathering what our participants' perceptions are on the first topic, and then giving a little presentation about that's related to that first topic, and then getting perceptions on the second topic, and then another little presentation, and then the third topic. So kind of like breaking up the workshop intertwined in between the presentation. Maybe that's another way to go about it. I don't know, Alice, if you have other thoughts on that.
Well, yeah, I do just want to note that we thought about what you're describing, Hannah, and that's why we sent out the survey in advance of the workshop, because in theory, if we were to follow up, which obviously, Carly had to narrow the scope of what she was looking at, but what we'd love to do, and what someone could do if they were interested, is analyze the change in responses between those who filled out the survey in advance. They were sent out after they registered for the workshop. And we did ask in the survey that Carly created for the interactive portion of the workshop, whether they filled out that survey before, and whether or not they'd filled out our survey for 2019 from ClinGen. So we have some data about, who's participated in the survey before, who's been exposed to the concepts, and we sent it out in advance of the workshop so that we could actually compare the results before and after the talk. But it's not exactly the same sample, because not everyone will have filled it out. But I think we got a decent number who filled it out in advance of the workshop.
Mm-hmm.
And also the idea was, once they were in small groups, I don't think this was described in as much detail, Carly, as it could have been, how the participants were grouped together randomly in breakout sessions, and then the survey that they're completing during the workshop, they're doing it together, sort of. They're doing part of it on their own, like everybody individually answer these questions in the survey. And then there are prompts in the survey itself that actually encourage conversation among your breakout group members. So, how was that question for you? What was your response? And then they sort of discuss together, like maybe why their responses differed or why they were the same. And then they reported that back to us as well. And I think, the design choice to have everyone fill out a survey as they're working with their breakout session group members was so that people could share things individually and anonymously that they may not want to share with their colleagues, and that we would get a report from each member of the group, rather than have one scribe be just telling us what they thought about the group discussion, but to hear from everybody in the group what their experience was. So there's a lot more data here, I think, that could be described and analyzed.
Yeah, and I think too, that also kind of led into that did, add as part of that vagueness limitation too, because in some cases participants did just, they didn't really elaborate on what they chatted about in their groups, but rather just said like, we all agreed, or we had no differences, or something like that. So it was sort of, a vague response, and how that information kind of informed their perspective or may have differed.
And this is actually, I don't know how you'd assess for this in a survey, but one other consideration as you are moving forward, just in general in the area of consensus building activities, I'd be interested to know what social conformity pressure there is from people that are actively engaged in their respective professional societies. It'd be interesting to hear from Altavis and Rachel and whoever else is a genetic counselor on this call. There's been a lot of effort with NSGC to educate people, I guess is maybe the phrase on these ideas, but I think it's become to the point that there are people that parrot and don't actually have a personal opinion on some things. And of course, that's a hard thing to assess and not something you want to generalize in an uninformed way. But I think it'd be interesting to know who has heard this in other talks or who is engaged in different communities, just to see, yeah, again, trying to look to see if there are patterns for where people have variable answers and things like that. Because it is interesting with it being mostly giant counselors and having very similar responses. And yeah.
Yeah, I don't know. That's a good, if anyone knows of studies that can tease apart responses that are just sort of performative versus those that are genuine or are understood.
Yeah, I don't know of any of those studies. I would actually be surprised if any of those studies are being conducted. Maybe in about a few years, I can anticipate something like that really being questioned, but I'm completely unaware at this time.
Okay, so we have a comment from Rachel. In clinical care, we would use Ancestry as needed if it enabled a patient to meet criteria for testing, but did not limit testing based on Ancestry. I would say there's a lot of pressure to give the right answer in group discussions of race, ethnicity, and Ancestry. Yeah, absolutely. And I think that's a really interesting point about the sort of the pressure within the group setting. Or I wonder though, in the context of an anonymous survey, we did get some very colorful responses to people who were unhappy about being asked to do this this workshop. So, I mean, it sort of seemed to me like the participants felt comfortable in their anonymity. I don't know, Carly, if you felt the same way.
Yeah, and it seemed to me that they felt comfortable in that. Like Alice said, there were, a couple of responses that I didn't actually include in this presentation, but some that were kind of just stating that they were, frustrated by, having to answer these questions. Or I guess that one of them, now that I'm thinking about it, did, say that they would have preferred to have a presentation over, a workshop. So there was one person that did mention that. But that kind of goes along too with what someone may expect is coming from, a virtual conference that they signed up for and what they were hoping for as well.
So Hannah, feel free.
Well, sorry.
Go ahead, Sharon.
No, I was going to say, I do think it really depends if you're viewing these workshops as a form of research, in which case there are people that research focus groups versus surveys versus workshops, or whether you're sort of viewing this as sort of professional education / development. And it's not quite clear to me which is sort of the intention. Is this how geneticists are going to come to decisions about the best use of this, or is this more you're trying to do research on people's perceptions of it? The idea of the workshop, that's why I'm just unclear on the overall sort of goal.
I think Carly, I'll let you answer, and then I can fill in if you.
Yeah, I think it's a little bit of both in a way. I think there's a level of, educating a little bit more about the topic and, the current issues that are associated with it. But then there's also the level of, at least in our study, trying to gauge, how genetic professionals, if they're using this information, how they perceive the information used in their own clinical or research settings. So I think it's a little bit of both in terms of, trying to educate as well as trying to get that information to guide any future, standardization or consistencies across the board. But I'll let Alice sort of, if she has any additional thoughts on that question.
Yeah, I mean, I guess I can share initially when we were planning this, the main thing that we really wanted to get out of this workshop was figure out what the use cases are for the different race, ethnicity, ancestry applications in clinical genetics. Remember that, Carly, our first question is sort of what are your use cases, but people don't know what that means necessarily. And we are at time. So thank you for those of you who are here, and please feel free to hop off if you have to go. But the real meat and potatoes of the data that I felt like we needed to collect was on those other uses of race, ethnicity, ancestry in their clinical work, so that we can amass all of the use cases that people have given us. The other information that I think we get from the research side of this, is studying how people process this information so that we can make future workshops better, basically. So not that we would publish on this is how genetic counselors think about race, ethnicity, ancestry, but we would really the purpose is to have an intervention and have an experience, educational experience, rather than listening to a talk. So being able to process in real time with group members who are your peers or people in your field that you feel somewhat familiar with, so that you can work through the topics in your own mind. And then what we're keeping is sort of like the metadata of that experience, but not necessarily like, generalizable research findings, other than maybe the use cases. Okay, I see there's literature on social disability bias and surveys that would be useful to review. Involving sociologists or behavioral psychologists could be insightful for addressing personal attitudes, practice versus group norms, expectations. There's been a strong convergence in the genetics literature to specifically refer to race as a social construct, but what that means is very rarely explained, and ancestry itself is often undefined and or has very different definitions. And as the genetic counselor field is making efforts to address its whiteness, many are treading very carefully in public discussions. All these fantastic points. And so I will be saving the chat, but I wanted to read those out for the recording. If there's any other, Carly, any last words or things that you'd like to share before we go?
No, I just want to thank you all for, giving me the opportunity to present all this data to you all, and I appreciate you all for listening.
Wonderful, thank you. And thank you so much, Carly, and great job.